Good morning, Chicago. I'm Dr. Allison Already, Commissioner at the Chicago Department of Public Health. Today is Tuesday, February 21st, 2023, and I want to thank you for joining us. As always, this is your chance to get your public health questions answered, COVID-related or non-COVID related. You can use the hashtag AskDrArwady on either Facebook or Twitter, or you can put your questions directly into the box below. As always, we'll go over COVID data, we'll talk about some non-COVID topics, and then in the second half, we'll get into whatever questions you have about public health. So to kick us off, let's start off with our COVID dashboard, chi.gov/COVID-. As you can see, Chicago's COVID-19 risk level is still low, which makes me very happy. And if we look at the details here, everything is still looking good. We're averaging around 330 lab confirmed cases in Chicago residents every day. That's flat from a week ago, so no, COVID is not gone. And remember, lab confirmed, these are generally people who have gone to their doctor to get a test or gotten a PCR test, as opposed to all of the at-home tests, which is of course how most people are currently being diagnosed with COVID. We've still got just under 20 Chicagoans being newly hospitalized with COVID every day, but that's down, as you can see, from January. And flat. We've had more than 50,000 hospitalizations of Chicago residents with COVID. We're averaging less than a death per day, also not gone. More than 8,000 Chicagoans have died from COVID. We're still doing more than 1,000 COVID vaccinations every single day. And less than 2% of our emergency room visits and about 3% of our hospital beds right now are taken up by COVID patients here in Chicago. So everything looking really status quo there. I'll remind you down below here is where if you want to see what's happening with community risk levels across the country, we continue to update 7 days a week our Chicago hospital capacity data here. So if you want to see what's happening with hospital beds, COVID, non-COVID, etc., it's all in here. This is a lot of information about wastewater surveillance. This is where you can see things about variants and genomic surveillance. This is our vaccine coverage data that does include the booster data. Our vaccine effectiveness data, comparing the rates of hospitalization, infection, and death in Chicagoans, comparing those who have never been vaccinated, those who had their original vaccines, and then those who are up to date with their boosters. We have some older social impact data, our data portal, where if you want to download any of this and explore yourself, our Chicago Health Atlas, which is the landing page for all of the other health department data that's meant to be community focused, and then some older data reports. So let me go ahead and switch to the update here. I was off last week on vacation, which was very nice. So it's been a little bit since we've had a chance to update, and since that time we have a few updates here. So first of all, you may have seen that Moderna announced that everyone will be able to continue receiving Moderna's COVID-19 vaccine regardless of their ability to pay, even after the public health emergency ends. Now, this is also true for Pfizer, it's also true for Novavax, it's also true for J&J. The question for me is a little bit more of what happens in the fall, as we talked about the last time that we were here. As the public health emergency ends this spring, we still have quite a lot of stockpiled vaccine, and that will remain. It's already been purchased, it remains available. But I think the bigger question will be if we need to do an updated vaccine, for example, this coming fall. I don't know for sure what it'll look like then, but still, this was good news to see from Moderna. Also, just briefly on the front, both the Novavax and the J&J vaccine are starting to get near the end of their shelf life. So if there's anybody who is still waiting to get a vaccine and really wants to get either a Novavax or a Johnson & Johnson, you really do want to get on that just in the next few weeks, because as those stockpiles run out, we don't expect them to be replenished again, possibly until maybe next fall. So vaccines remain widely available and free to all, and I don't expect that to be changing anytime soon. Also, since we last spoke, we had our documentary premiere screening of HIV and the Journey Towards Zero. On February 7th at Malcolm X, we had around 300 people there, and it was a really good conversation. And basically, if you want to get more information, we will have some future screenings. It's a story about Chicagoans telling their stories about living with and fighting HIV. So journeytowardzero.com is where you can go for more information. And we do expect to have some additional screenings of that. But that was a really celebratory event, and I want to thank everybody involved, particularly from our HIV team. Also, since we last spoke, we had an event with members from our Trauma-Informed Centers of Care network. Just as a reminder, this is about our mental health approach here in Chicago. So we convened with members of the TIC, Trauma-Informed Centers of Care network, and to celebrate the fact that now there is at least one City of Chicago funded trauma-informed centers of care facility in every single one of our 77 community areas. Every one of our neighborhoods, there is now a clinic where you can get mental health services, regardless of your income, regardless of your insurance status, regardless of your ability to pay, regardless of your immigration status. And if you look here, in 2019, you see on the left, the blue dots, where the City of Chicago was funding mental health services. We were directly operating some clinics. We were funding a few other organizations doing no barrier, high quality mental health. And during the pandemic, one of the things behind the scenes that we've been working on the most is increasing that no barrier access to mental health care. So really proud of this progress. You see on the right, all of those red dots represent mental health service locations that are no barrier and really represent a huge variety of trauma-informed, culturally relevant services. So this is a mix of more traditional spaces like federally qualified health centers where people may be getting their primary care. They've now gotten additional funding to have more mental health staff on the team. It's also funding some of the primarily state-funded mental health providers, county-funded, city-funded, and then interestingly, there are now more sites where we've embedded therapists into new locations. Instead of waiting people to come into a clinic, we know still with stigma, there are people who don't want to get mental health care in a mental health clinic. We have some of our partners now have fully licensed therapists who are doing individual treatment through food pantries, at schools. We have some programming that brings mental health services outside of the walls of clinics to people who may be experiencing homelessness or who are otherwise not really stable enough to keep an outpatient appointment. So we continue to operate the CDPH clinics, very proud of the advances there, but even more proud of the fact that we've built this network, we've built this system, and we've gone from serving about 3,600 Chicagoans on the left there in 2019 to over 70,000 last year. So again, big shout out to my whole mental health team and to the many partners involved. And just as a reminder, to get connected to mental health services in your neighborhood, you can go to mentalhealth.chicago.gov or you can call 211. That is the new number 24/7 for residents of Chicago and of suburban Cook County to be able to access health and human services needs. So unspoken remains the focus of our campaign. We want mental health to be something that we talk about. We don't want it to be unspoken. And then I wanted to highlight, right now we are expanding our CARE team. That's the Crisis Assistance Response and Engagement, the alternate 911 response, where we embed mental health professionals into 911 response. And so we're hiring 5 additional mental health crisis clinicians right now. You can see the salaries, almost $78,000. The qualifications are there. These are for accredited folks with a master's or doctoral degree, as well as at least 2 years of experience. And there's some more information there, but the deadline to apply is March 2. So if you know folks who are clinicians, are very good at mental health crises, we are expanding that team to more areas across the city, and very excited about that. All right, on the COVID front. So we are at a low COVID level. Here's the data that is based on, both for the city of Chicago and then for Cook County, including the city. You can see for new cases, that's lab confirmed cases. Our goal is to say less than 200 per 100,000 population over 7 days, and we're well under 100 for both the city and the county. For admissions, we want to stay less than 10 new admissions per 100,000 population over the last 7 days, and you can see we're well under that at both the city and the county level, although the county is tracking a little higher than the city in terms of COVID admissions. And then our percentage of staffed inpatient beds occupied by COVID patients. The goal is less than 10%. You can see we're well under that, right around 3%. So that is why we are at a low level. And last week, 2.5% of U.S. counties only reported a high COVID community level in orange there. You can see just that one in Illinois. And 20% were reporting a medium level in yellow. Still the Northeast seeing a little more of the medium, but Illinois looking good, and very happy for Chicago and Cook to be at that low level. If we look at our variant surveillance, very high level, we've been following this XBB.1.5. Every single subvariant and variant that you see here is all still Omicron. That's the most important news. It is the best news because it means that our vaccines continue to be broadly protective. It's important that you stay up to date. The vaccine update that was released right around Labor Day of last year was the updated vaccine made specifically to better help protect against the Omicron subvariants. And so the fact that everything has still been Omicron is the most important news. But the subvariant of Omicron, the XBB.1.5, it's in purple on the graph there. You can see moving to the right, these are the percentages that we're seeing in the Midwest, and we're now up to about 3/4 of all of the COVID in Chicago in the Midwest is now this subvariant, this XBB.1.5. It's the most contagious subvariant yet, but we have very good tools, whether that's vaccines or early treatments. And if we look at the US, you can see that XBB.1.5, again, that's the purple. It is almost all of the cases now on the East Coast, and it will be almost all of our cases here too. It's been growing just like we expected that it would. Here's how we're doing with our updated booster coverage. The booster here does reference that updated COVID vaccine made specifically for Omicron and available since last Labor Day. We've given well over 500,000 doses, 568,000 doses. We are beating the national average, but I'm still worried by how many Chicagoans did not come fully up to date there. So I just want you to remind you, everybody over the age of 6 months is eligible for and should be coming up to date. Vaccines remain free and widely available, especially people over 65. This does continue to increase every week, but still just 41.2% of the population over 65 here in Chicago has had that updated booster, and that is by far the age group most likely to be hospitalized or still to die of COVID. We continue to operate our Protect Chicago at Home program. That's the program where we will bring vaccine to your house free of charge. Vaccinate up to 10 people. So you can get your COVID vaccine, you can get your flu shot if you haven't done that, as long as somebody's getting a COVID booster. And you can register for an appointment by calling us at 312-746-4835 or go to chicago.gov/at-home. We are committed to continuing this even as the emergency ends. We found it to be very helpful for people who have a range of barriers to be able to go out and get vaccinated. I also want to give a thank you to the City Colleges of Chicago. We hosted our last large clinic of the season earlier in February. We will plan to be working with City Colleges again next fall as we have the flu vaccine and quite likely an updated COVID vaccine. But to date, we have hosted 589 clinics with City Colleges, and you see the numbers here, 148 at Malcolm X, 131 at Richard J. Daley, going all the way down. And we've done almost 128,000 COVID-19 vaccinations at those clinics. So again, a big thank you to City Colleges and to everybody who came out. We also will continue this kind of partnership in the future. I want to remind you that nothing has changed if you test positive for COVID-19. Days 1 through 5, you should stay home, regardless of your vaccination status. If you're at higher risk for severe illness, if you're over 50, if you have an underlying condition, please talk to your doctor about getting early treatment. You want to take that early treatment before you get really sick. The way it works is it helps keep the virus from copying so much in your body. And so sometimes I heard people say, oh, I don't think I'm that sick. I think I don't need it. If you're at high risk for severe outcome based on age and underlying conditions, you want to take it before you're seriously sick. That's really when it works. You have to take it at the beginning. And then day 6 or later, you can come out of isolation if you're feeling better, but you do need to wear a mask days 6 through 10. In those days 6 through 10, just do be careful around people at high risk of getting very sick. Better to postpone a visit to great grandma, for example. I also do just want to go a little deeper on the COVID treatments. It's what we are still getting a lot of questions about. So as I said, if you test positive and you're at high risk of severe illness, contact your healthcare provider. People say, what if my healthcare provider doesn't want to give me Paxlovid or I can't get in touch with anybody? We have a test to treat location. Those are pharmacies. Here in Chicago, you can get a test on site and you can get a prescription on site with the pharmacist looking at your medications that you're prescribed, making sure that there's no problems with drug interactions. And you can also just call us at 312-746-4835, 7 days a week. And folks representing CDPH will help you figure out how to get access. Because you've got to begin the treatment just within the first few days of symptom development. There's more information at chi.gov/therapeutics. So together, I always say, think about Vax and Pax. That's Vax and Paxlovid. That's our belt and suspenders. Be up to date with your vaccines. And then if you get COVID, regardless of whether you're up to date with your vaccines, if you're at high risk, you want to get Paxlovid or one of the other antiviral therapies. Again, you want to get this when your COVID is mild to moderate to help prevent you from developing severe illness. And individuals age 12 and up are eligible. 12 and up, those younger people would be for folks with underlying conditions. Here's a little bit of data about how much we've been using these oral antivirals in Chicago by the drug type, going back to when they were first available. About a year ago is when they were first available. They were given their authorization status in late December 2021 and started to roll out in the first quarter of 2022. So on the graph here on the left, that is the first quarter of 2022, just as these were starting to be available. In red is Paxlovid, in blue is molnupiravir, and then the green line shows you the number of new COVID cases among Chicagoans, specifically those over 50, because that's who we especially want to see protecting themselves with oral antivirals. And so you can see that in quarter one, we had fewer than 1,000 Paxlovid prescriptions and fewer than 300 molnupiravir. Then in quarter two, we were up to almost 12,000 Paxlovid prescriptions, got over 13,000 in quarter three, but then we've seen some of that fall off a little bit. So in quarter four, we were down to about 9,000 Paxlovid prescriptions, another 1,000 or so molnupiravir. And you can see that cases in green were down a little bit, but we're still concerned at the health department that there's a big gap between the number of Chicagoans over 50, which was 16,000, who were diagnosed with COVID-19 formally, and then the 9,000 or so who were prescribed Paxlovid. And then quarter one, we're still in quarter one, but you can see there's been quite a big drop off there. Some of that makes sense because cases are down, but I just want to remind you that anybody over 50 or with underlying conditions, if you do get COVID, really do recommend at least a conversation with your healthcare provider about potentially taking an oral antiviral. And similarly, if we look by facility type over the last year, in purple here are pharmacies. So the great majority of prescriptions are being filled by commercial and independent pharmacies, a much smaller number at federally qualified health centers in red, hospitals, independent clinics, et cetera. And there are publicly available sites where you can see where therapeutics are available. All of these, you can find all of this if you just go to chicago.gov/therapeutics. But I just wanted to show you in the blue dots here, this is really meant for patients where you can put in your address and then see where you can get a test to treat location that can prescribe it for you, should that be necessary. And then also for providers, if providers want to see where are therapeutics available, if, for example, you have a patient who needs renal dosing, meaning a lower dose for somebody who might be on dialysis or have other kidney problems. You can see right now in the city there's over 800 places that have Paxlovid and other therapeutics available, and we have 1 million doses available of molnupiravir, 36,000 on the shelf of Paxlovid, 5,000 of renal Paxlovid, plenty of availability. So just wanted to highlight some of this for you. And then just as a reminder, as always, if you need help for any health or social service needs here in Chicago or suburban Cook, for about the last month or so, you've been able to call 211 or go to the website 211metrochicago.org, and people can help navigate you to whatever your needs are. And then for COVID questions specifically, we continue to operate 7 days a week, the hotline 312-746-4835, or you can visit chi.gov/COVIDVax. So with that, I will end the slideshow and we'll go and turn into your questions. If I can get the computer to work. Sorry. Just having a little bit of technical problem. There we go. Okay. All right, so a couple good questions coming in. Rico MJ Hampton on Facebook is saying, can someone be tested and it shows that they've had COVID before, even though they may not have it now? All right, so the main COVID tests that everybody's used to, whether that's the over-the-counter tests or the tests that you would take in a laboratory, the ones that are a nose swab in particular, those are looking for active COVID infection, whether that's a PCR or an antigen test. What you're asking about is an antibody test. An antibody test is a blood test, and it's not really a test that your doctor is going to offer you. It's not something that changes anything about how we treat or how we would approach COVID risk. So it's not offered routinely. There are places that you may be able to get it, but we use these antibody tests to help understand how protected a population is against COVID-19. So let me put a little more detail on this. The problem is that one antibody test is not the same as another antibody test, is not the same as the third antibody test. And if you're doing a population level study, for example, you can check and compare between antibodies that you got from getting vaccinated, the safer way, as compared to antibodies that you got from getting COVID. And so at this point, 99% of Chicago has antibodies to COVID one way or another. But a basic test isn't going to necessarily differentiate for you whether you have your antibodies or your protection from having the COVID vaccine or from having COVID-19 or both. The tests can be both qualitative, meaning yes, no, and quantitative, meaning you can see how high the levels of antibodies are. And so when we're developing vaccines or we're looking to understand how well the therapeutics are working, in those studies, as those new technologies are being developed, quite often they're checking blood regularly on people to see what the antibody levels are like. The idea when you develop a vaccine is you want to give people a high enough level of antibodies so they have that protection. Antibodies do not make you sick. Antibodies are your immune system sort of learning its lesson, and the antibody is what your immune system then uses to fight off COVID the next time. So I hope that clarifies. There is not an over-the-counter test that I am aware of that would answer that question. You would need to get a blood test, an antibody test, but really most of those antibody tests aren't going to really differentiate between antibodies from a vaccine or antibodies from being infected. So talk to your doctor if you have more questions. It's most relevant, these tests, for people who may be severely immunocompromised, folks who have just had an organ transplant, for example, because often you might give somebody a vaccine, you'll check that antibody test, and if their antibody level is not high enough, their titer is not high enough, you know that that vaccine hasn't given them enough protection. But for somebody who has a regular healthy immune system, there's not really a lot of diagnostic or therapeutic need generally. So good question. Hope that answered it. Talk to your doctor if you have more specific questions about your health condition. Katrine Kumar from Facebook says, thank you for continuing to offer these information sessions. Can you please speak to the increase in norovirus cases? I'm at a school. We're seeing a lot of acute gastroenteritis and are already reporting cases to CDPH. Yes, so thank you, Katrine. So during the winter is when we will often see an increase in different kinds of viral illnesses. Norovirus, for those who may not be aware, is a very common, very easily spread virus that has nothing to do with COVID, but it is spread often if people are not washing their hands well after using the bathroom. It usually, there's some what we call fecal oral, where you have some of the norovirus germs that are in somebody's stool from diarrhea, and then inadvertently, when somebody doesn't wash their hands well, perhaps, they then eat food or in some other way, they are getting those germs in through the mouth, and then therefore it spreads. And so norovirus, we often see outbreaks of in schools, in prisons, sometimes in workplaces, on cruise ships. These are the ones that are famous for making people sick on the cruise ship. And for most people, norovirus is not a life-threatening illness, but it can make you, it gives you stomach problems. It gives you diarrhea, sometimes nausea, vomiting, etc. And it doesn't last that long, but it can be pretty uncomfortable. And so when it happens in a school setting, for example, since that's the one you're asking about, first of all, I was glad that you said you're reporting it, because CDPH, this is an example of where we get reports about norovirus or any kind of outbreak, right? This is something we did long before COVID. We have a school health team. They're tracking that. They're making sure that the appropriate cleaning protocols are being followed, because you do some extra cleaning if you have a norovirus outbreak. We're monitoring that with the school. If you get to a particular level of number of students or number of staff being out, sometimes we have to make some decisions there. But this is sort of a basic run-of-the-mill, but it can be pretty uncomfortable. And it can spread easily. So just a good reminder for everybody that if you're sick, masking is for the respiratory viruses, but hand washing is especially for all of those, what we call fecal oral, the viruses that kind of spread through poor hygiene. And young children in particular have to be taught sometimes to really do a good job of washing their hands after using the bathroom, washing their hands before they eat, using sort of extra hygiene. And so it is sometimes in younger children, in daycares and young school settings that we will sometimes see outbreaks like that. So good question. But acute gastroenteritis is something that often comes around, and it is no fun. So if you work in healthcare in a school, I feel for you if you've had a norovirus outbreak recently. But know that as long as you're doing all the right protocols with the cleaning, it offers a good opportunity just to review hand hygiene and to have people, stay home when they are acutely unwell. And there's more information if you want to read about it on the CDPH page about norovirus. Okay, James from Twitter says, what's the status of monkeypox these days? Is it still worth getting a vaccine if cases have been so low locally? Yeah, good question, James. So monkeypox, or what is now being called Mpox, is still here in Chicago. It's still around the world. Why don't we actually pull up the website? Can you pull up the computer for me again? If you go to chicago.gov/Mpox or /monkeypox, here is our page with all sorts of information. What do you do if you're sick? What do you do if you think you're exposed? What you should know? How does it spread? But also, we continue to update the data dashboard here. So if you take a look, let me let it load. So we've had about 1,121 cases in total diagnosed in Chicago residents. 76 of those people needed to be hospitalized, and 3 have died. And if you look sort of in recent weeks here, you see that we're still seeing some cases. Nothing like we were seeing back last summer, but still 1, 2, 3 a week, most weeks. And one of the things that we're seeing a little bit different with the more recent demographics, if you take a look at the case details here, it does tend to still be largely in younger people, especially people in their 20s and their 30s. Many more men, about 92%. But we have had 12 women, and actually in recent weeks, we've had more cases in women, and women who report a straight or heterosexual orientation as well. We know that people who are having multiple sexual partners, especially anonymous sexual partners, are at higher risk for MPV. And I want to remind people that skin-to-skin contact can spread this, even outside of having sexual intercourse. And so we've seen transgender transgender men and women, people who are non-binary, all groups sort of be affected. And although about 65% have reported gay or lesbian orientation, 6% bisexual, 5% straight or heterosexual, 23% have not reported or it's been unknown. I do just want to note that we are still, although the cases are relatively low, we are definitely still seeing some cases, and that continues to be, the biggest risk factor is having multiple and especially anonymous sex partners. So just a reminder that vaccines do also remain available there. Here's our vaccine data. We've given almost 50,000 doses, but only about 30,000 first doses. So we saw about 20,000 people not get their second dose. And I can tell you, I actually looked at this recently. Over the last few months, just where these numbers have been pretty low, the last dozen cases or so, 11 of those people were unvaccinated. So it continues to be a risk. So for people who are at higher risk, there's lots more data about what that looks like. You definitely should still get a vaccine. And if you only got your first dose, I would recommend getting the second dose because that seems to make a difference in the larger studies. Here's data about who has gotten their first dose, who has gotten their second dose, and you can explore more there. If we come back to the home page, I just want to remind you here, because it's been a while since we talked about it, it's painful and uncomfortable rash or sores, often accompanied by flu-like illness, and it can require hospitalization. It's the same family of viruses that causes smallpox. So milder symptoms, but people can get pretty sick. And Mpox is not related to chickenpox. Anyone, regardless of sexual orientation or gender identity, can get Mpox through close personal contact with anyone who has symptoms of Mpox. But the data suggests that it's primarily spread among social networks of gay, bisexual, and same-gender loving men through intimate contact. And then risk is especially high for same-gender loving men with multiple or anonymous sexual partners. So that's who really should be getting vaccinated. And the Jynneos vaccine is recommended for all sexually active, bisexual, gay, and other same-gender loving men, transgender persons, and anyone with close contact with anybody diagnosed with Mpox, regardless of sex, gender, or sexual orientation. So if you're seeing a rash or unusual sores, please go get checked. Your doctor can test. You don't need to go to a special clinic, but if you get tested, then we can get vaccine to any of your close contacts and help to stop the spread. So feel free to read more about that here, but that is what is currently going on with Mpox, and thanks for that question. Patty Graff from Facebook was asking, how about another round of bivalent vaccines for elderly and vulnerable this spring? I understand that it's being discussed. So it's been discussed. At this point, there's not another recommendation for another round. And this is a recommendation that would be made at the national level. That isn't one that CDPH would make separately. And it's based on how we're doing with COVID overall. But it's also based on the fact that we've seen if people get that updated bivalent booster, that those antibody levels that I was talking about remain relatively high enough to be protective, especially against the severe illness. That's what they're seeing in the larger studies. And so there's no, at this point, no further recommendation for another round of bivalent vaccines. I do think it's quite likely in the fall we may see another round of vaccines. We make a new flu vaccine every year based on the strains of flu that have been circulating, and it wouldn't surprise me, depending what happens with COVID, if we similarly make an updated vaccine each fall to better fight off the strains of COVID that are out there at the time. But we'll see. We'll see how we're doing with COVID. But otherwise, if you're up to date, you are good. Just make sure in the event you do get diagnosed with COVID, if you're older or have underlying conditions, you want to have your belt and suspenders, you want to also think about getting Paxlovid or another oral medication. And Faye State, I see your same question. Any decision on a second bivalent booster? Nope, not at this time. The ACIP, the Advisory Committee on Immunization Practices, continues to meet. They really look at CDC. They look with CDC at COVID, vaccine, and other data pretty much every month. And so, if there's updated news there, we will let you know. And then Maribel on Twitter is asking, can a woman who is pregnant that has COVID infection be treated with the COVID medication? So that is a question for your doctor, for your OBGYN, but generally speaking, yes, because we know that women who are pregnant, when you get pregnant, your immune system is changed to make sure that you don't reject the fetus that is growing during your pregnancy. And so we see a lot of changes in women's immune system during the time that they're pregnant. For example, often people who have a lot of allergies or who have very bad asthma can sometimes see that calm down a lot during their period of pregnancy because their immune system is not reacting quite as aggressively. But on the other hand, if they do get sick, if they get a viral infection, for example, of some kind, their immune system is also not going to fight it off potentially quite as strongly. And so that's part of why we see worse outcomes for people who are pregnant who get diagnosed with COVID. It's why it's especially important that women who are pregnant or thinking of becoming pregnant get up to date with their COVID vaccine. So you're as protected as you can be in the pregnancy. And then also babies can only start getting vaccinated against COVID at age 6 months. And for those first 6 months, they're dependent on the antibodies from mom through the placenta. And so it's really important to come up to date with vaccine, but also generally speaking, you're going to make that the decision with your doctor, but they may, especially if you're not up to date with vaccines, they very well may make that recommendation to take the medication. But talk to your doctor. The more important thing, I think, is to make sure that anyone who's thinking of becoming pregnant gets up to date with all of their vaccines, actually. And it's something that our prenatal providers are very well trained to do. And a question here from Megan. What do you make of the Cochrane Review saying that masks don't make a difference? So for those who don't know, the Cochrane Review is a really good what's called meta-analysis, where they look at published randomized controlled trials and try to pull together all of the randomized controlled trials around a particular question and then see if you can pool that data to make larger findings in medicine. So the Cochrane reviews are very high review, and there was a Cochrane review out maybe a month ago that was trying to pool together randomized control trials for all different viral illnesses, actually wearing masks, and some showed some effect, some showed less effect. I think from the reading that I've done there, one of the challenges is that a lot of the different viral illnesses have pretty different they're quite different in terms of how contagious they are. And so, like, I saw a second meta-analysis, for example, that somebody did that pulled influenza out and said, let's look at COVID, and it did see some effectiveness. But I think more to the point, there haven't actually been a lot of really high quality randomized controlled trials of this because it was all happening during a pandemic when people are first and foremost needing to make the recommendations that they think to be best to help protect individuals. So there was a good study out of Bangladesh, for example, where they didn't have enough masks, and so they randomized whole villages to either the villages got the masks for free or they didn't get the masks for free, and then they compared what happened with infections in a community that had masks and a community that did not have masks. And they did find a reduction in COVID cases in the communities that had masks, about a 9% reduction. So, not enormous, but a reduction. I think the other challenge is that you're pulling together really different settings. So a village in Bangladesh is going to be really different than ICU in the US and looking at practices of masking in clinical settings. So I think I'm very glad that these studies are continuing to be done. I think they're important. We clearly are able to show in a laboratory setting that masks make a big difference. They make a big difference in terms of the number of viral particles that leave your vicinity, and they also make a difference in terms of the number of viral particles that you will inhale. But a lot depends on the type of mask too, right? And so these natural, the example of the natural experiment, like in Bangladesh, where you can literally compare two similar villages. We don't have a lot of those comparison type studies here in the US as much around masks. And you know as well as I do that not everybody wears a mask, even if it's at a time that it's recommended. Everybody wears masks. Some people wear them very faithfully. Some people sometimes wear them. And then there's different kinds of masks, right? There's the surgical mask, there's the cloth mask, there's the N95s. So the challenge always is translating what we see in a laboratory setting. What does that look like to translate into the real world, implementation science? I think I'm glad that these are continuing to be studied. And, you know, I know that masks are a part of the solution here. Are they the whole part? No. Is the vaccine the whole part? No. Is the treatment the whole part? No. But all of them together really help. And especially at a time of surge, especially to help protect vulnerable individuals, they do play an important role. Okay. And so similar to the monkeypox question, is it still worth getting the bivalent booster when cases are so low? Yeah, it is. So the bivalent booster, remember, that's the vaccine that came available in last Labor Day, and it's the one that was made specifically to fight Omicron. When I'm in clinic seeing patients on Saturdays, a lot of my patients still don't actually fully realize that they need another booster. A lot of them, you know, I saw a woman a week or two ago who had had 3 or 4 vaccines because she was older, but she hadn't had one since last June. And so I said, oh, actually, there was an updated vaccine, and she then got her updated booster. It's the first time that the vaccine itself was updated to better match the way that the virus has continued to mutate. So all of the vaccines before last Labor Day were made against the original version of COVID, the version that emerged in Wuhan, China. And thankfully, they showed pretty good cross-reactivity, pretty good protection. But we saw, especially when Omicron hit in January, that with that version of the virus, it was so contagious and it was able to evade more of the immune protection. We saw a lot more breakthrough infections. And so because of that, the decision was made to update the vaccines to better protect against Omicron. And so right now is absolutely when you should get your bivalent booster. Even though the numbers are relatively low, if you have not had a booster since Labor Day, it's time. And that's true really for anybody over the age of 6 months who isn't up to date with vaccines. You want to get it now while we're in winter. And I wouldn't wait. People are asking, should I wait to time it with a vacation? Should I wait to time it? No, just get it. That would be my recommendation. And then Bob from Facebook says, Jonathan Toews from the Blackhawks just announced he's going to take a break while he deals with the symptoms of long COVID. What do we know about long COVID? Yeah, good question, Bob. So long COVID is the generic term for what we're calling post-COVID conditions. And one of the challenges has been that there isn't actually a single agreed upon constellation of symptoms that makes up, quote, long COVID or post-COVID conditions. So the Department of Health and Human Services developed a working definition, but people will call it long COVID, long haul COVID, post-acute sequelae of SARS, COVID infection, so PASC, long-term effects of chronic COVID. And we've seen this condition can last for weeks, it can last for months, it can even last for years. Post-COVID conditions, more often found in people who have had severe COVID illness, but anyone who has been infected with COVID can experience post-COVID conditions. The good news is we were seeing a lot more people develop these post-COVID conditions in the first year or so before there was a vaccine. Once there was a vaccine available, we actually saw some people, this was a surprise to everybody, we saw people who were having long COVID actually see their symptoms remit, get better when they got the vaccine. It seems to have like given their immune system an extra boost to help sort of fight off some of those symptoms. But we also know that there are a lot of people still suffering with a lot of effects of these post-COVID conditions, and we're still learning, honestly, about what it is. We know it's your immune system in some way not responding exactly correctly. But again, there's a wide range in what we see. So again, getting vaccinated is important. We know that people who are not vaccinated against COVID, who become infected, have a higher risk of developing post-COVID conditions compared to those who are previously vaccinated. So I sometimes say when like young, healthy people right now ask me, you know, do I really need to get that booster? Do I really need to get another COVID vaccine? Partly I say, yes, you want to do that so you have the best protection, but also like you really don't want to be rolling the dice with getting a COVID infection. You want to do what you can to avoid it, not so much because of the risk of acute COVID. If you're young and relatively healthy at this point, you're probably going to do just fine because you already have some immunity from your other vaccines, from prior bouts of COVID. We of course have medications available, but I also don't want you to risk getting long COVID, even though the risk is lower than it was. It's not zero and it's not totally predictable. So there are a number of studies that are going on. And we have links to those on the CDPH website. This is something that scientists are going to be learning a lot about for years and years to come. And you can sign up for post-COVID studies. There are a number of sites right here in Chicago that are continuing to enroll folks. They'll enroll people who have post-COVID symptoms. They also are interested in enrolling people who don't have post-COVID symptoms to be able to do some comparisons there. The NIH is doing some larger studies of this. It remains a major impact of COVID that is not talked about quite as much, I think, as some of the other areas. We do not have a blood test for long COVID. We do not have a nasal swab to test for long COVID. It's still an area of a lot of active research, and I've talked about it a number of times on this show before. But maybe the next time that I'm on, I can bring some more of the more recent data, if you'd like, on what we are learning about long COVID, because I know that it's of some interest. All right, and so people are asking, how was my vacation? My vacation was very good, thank you. It's lovely to travel and to know that we are at a low COVID level here, and to know that doesn't mean COVID is over, but people are traveling in a way that we just couldn't a few years ago. And I liked seeing people putting the mask on the airplane, just a little bit of extra things, but COVID doesn't have to be top of mind. And that is true for me just as much as it's true for all of you, and that makes me really happy. And Larissa Simmer on Facebook, I see your note, I mask when I'm anywhere in public. Yeah, thank you. People make different decisions at this point, and for you, if you have an underlying condition or you're older, wearing a KN95 can really help limit your own risk, but it also, during respiratory virus season in general, it can help stop the spread of viruses to others. When we are at a low level, if I'm not having any symptoms, I don't always have a mask on in public myself right now. But I think of it like an umbrella. I always have it with me, and I pull it out and I put it on. If I'm going to be on the L and the L's crowded, if I'm sitting next to somebody in a theater and this person is coughing, I really want to put my KN95 mask on. If I'm going to be around somebody who I know is older, or I see that there are multiple people masking, it's a nice thing to do to show care for others, I think. And then always if I'm in a healthcare setting, if I'm in a hospital, if I'm in a clinic, those remain settings where masking does remain important at this point. So thank you for your decision to continue to mask even when we're at a low level, and it shows care for yourself, but I also frankly think it shows care for others. And I ask everybody right now to be kind, right? Be kind to people who are wearing masks. Be kind to people who are not wearing masks. And put a mask on if you are having symptoms, whether it's COVID or not. Nobody wants your germs. And I think probably for a long time in Asia, they were wearing masks a lot more than we were prior to COVID because they had SARS. SARS, severe acute respiratory syndrome, was another coronavirus outbreak. And because of the experience with SARS, there was much more masking. And so if you traveled to Asia, you'd see more people just putting a mask on public transit, or if they had a cough. And I think probably for a long time, masks will continue to be just a part, not an all the time thing, but something that we will pull out when we need it on an individual level. And then if there is some major surge at some point, it certainly remains one of the tools, along with vaccines, treatments, opening windows, all of those other things that can help limit risk. And then the last question here, the city colleges clinics are over. Are you still doing the vaccines at home program? Yes. So I said this earlier, Protect Chicago at Home is a program that we really think has been important. We continue to operate it. We'll probably pull the number of days that we're doing it each week back a little bit because it's expensive. But as long as there is some demand, and remember, more than 1,000 Chicagoans get their COVID vaccines every single day still, we will continue to operate that program. So 312-746-4835, give us a call. We'd love to come and get you and your family up to date with your vaccines. And anybody over the age of 6 months and up, the folks who do the vaccinating with our at-home program are really talented. They're really good. If there are people who are, a little bit afraid of needles or otherwise concerned, and I thank them and everybody who continues to work to protect Chicago. So with that, we will finish up for today. We are not doing a show next week. I will actually be in Washington, D.C. It's the Big Cities Health Coalition, one of our annual meetings, and I'm the vice chair of Big Cities Health Coalition. And so it's commissioners from the largest cities across the country, and we get together and we talk not so much about COVID these days, actually, but about what's happening with opioid overdoses and what's happening with violence intervention, and what's happening with infant mortality, and all of the other things that may be going on. And we're in D.C. partly because then we also are meeting with congressional representatives on the Hill, and making the case for why we need to continue to sustain public health infrastructure that has been built during COVID. So I won't be here next week, but the week after, March 7th, we're going to have some special guests on. We're going to have Aisha Jaco, who is the Executive Director of Westside United, and Theodore Crawford, the Executive Director for the Garfield Park Right to Wellness Collaborative, to discuss some great work happening on the West Side and through our Healthy Chicago Equity Zone out there. So looking forward to that conversation. Again, thinking about taking the lessons from COVID and what are we doing to promote health and health equity across Chicago overall. So that should be a really good conversation back on March 7th. In the meantime, you can continue sending in your questions. We do use them to update the website. Thanks, as always, for your attention and for everything you're doing to help keep Chicago healthy. See you in 2 weeks.